think we're good to go. Welcome, everyone. I'm delighted to hand over immediately because we've got a big panel and lots of stuff to cover here, I think. So delighted to hand over to Dr. Sohan Seth from the University of Edinburgh, who will kick us off. Thank you.
Okay, great. I hope you can hear me well. Thanks a lot for coming to the session, and it's really great to see all of you here. So I am Sohan. I'm the lead data scientist at the School of Informatics of University of Edinburgh. We are also part of the Advanced Care Research Center, and one of our panel members is from the Institute of Engineering and Technology. So what we'll do is that for the next hour or so, we will talk a bit about the role and perception of AI in healthcare. And this particular panel is in connection with another workshop that we organized last week. It was named Your Care, Your Future, a Creative Exploration. The idea there was to talk to public members about their role and experience with AI and later life care, and it went fantastically well. We learned quite a bit from our public members, and what we did is that we tried to integrate the comments they had in the panel discussion we are having now. So that said, you will also have an opportunity to answer some questions through a poll, and so each of the speakers, when they introduce themselves, they will have a question of choice that they already have given. And when the question comes to you, you'll have about roughly 1 minute or so on the screen to just give a yes/no answer. The questions are not designed to be right or wrong in any way, just to give an idea about what you think about the question and put it in the context of the research that is going on and activities being done by the panel members in place. So to quickly start things off, artificial intelligence and data science is kind of everywhere in the present days. And I was not here yesterday, but you probably talked about, listened from Gary Marcus, who talked about ChatGPT, one of the large language models that we use, which has been quite popular. And they are really good at generating text, data, and so good that you can even have a meaningful conversation with the machine. But the question is that, can we use that technology to replace clinical practices? Probably not. And if we want to use that to self-diagnose our symptoms, we should be very careful in doing that. And we have to understand the technology better, what they are doing, and try to understand if they are trustworthy, they are inclusive, and they are ethical for to use. And things definitely become more challenging when we talk about later life care, which is the focus of the Advanced Care Research Center, because as you grow older, you become more frail. You might have vision and hearing impairments. And one of the things that we learned from the workshop that we did last week was that because you are not familiar with the technology that much in your older age, you might be cautious or might be hesitant to trust what's being done. But that said, it still holds enormous potential to use AI in different contexts. And one of the contexts that we are interested in is multimorbidity. So multimorbidity is living with 2 or more conditions simultaneously. And it is a global issue because we live longer, and as we grow older, we accumulate more and more conditions in our old age. And our current healthcare systems are usually designed to tackle one problem at a time, and not together in terms of when 2 chronic conditions are appearing together. And that leads to what we call polypharmacy. So you are taking multiple pills at the same time, and they might interact and have their own adverse events happening. So the question is, with that problem in mind, which is a pressing global issue, how AI can help us in different contexts. And that is a discussion we wanted to have today, an open discussion about those topics. And for that, we have a fantastic panel in place here, and quite diverse, I might add. So we have Claire McRae. She's a GP, and she's currently doing a PhD associated with the Advanced Care Research Center. We have Dr. B. Alex, and she is a senior lecturer at the University of Edinburgh, and she's focusing on natural language processing. We have Professor Peter Bannister, and he is the executive chair of the healthcare sector at the Institute of Engineering and Technology. And last but not least, we have Jo Turnbull, among her many other roles. She is also one of the public contributor at the Advanced Care Research Center. So we can start from there, and the panel member will introduce themselves shortly. And as I mentioned, you will probably have questions appearing to you, each one question for each of the panel members, and try to put on your answer yes, no, while they are introducing themselves. And once done, we will reveal the yes, no proportion that you have given. And so without further ado, I will ask Clara. And for Clara, we had a question which is asked: 1 in 3 people in the UK above 60 live with at least 2 chronic conditions. So Clara, is that true? What do you have to say?
Are we voting about this?
I think they will be voting now, if I'm correct.
Voting now. Do we wait for the outcome?
Oh, no, you can go ahead, yeah.
Okay. So in the UK at the moment, we just released some results from a study using population from most of Wales. About 70% of the population of adults aged 60 years and above have 2 or more conditions. And that's roughly half that percent for people who have 3 or more conditions. So it's very common, it affects a lot of people.
Okay. Yeah, thanks so much. Do we have the poll given? I cannot see the screen yet. It might go. Oh, there. Oh, that's perfect. Thank you so much. Oh, quite a bit of yes answer to that. I think that's the right answer. That's fantastic. That went very well. So next, moving on, introducing B, and we asked the question, can you decide how healthy the inhabitants in your local area are overall, given its news reporting? So B, what are your thoughts?
Please have a go at voting for that question. So this question is actually the focus of a research project, a part of a research project called AIM-CISC, which is all about AI and multimorbidity. And my group, with members from the clinical NLP group in Edinburgh, working on natural language processing, are looking at analyzing news to see if there are topics that can emerge from news that can tell you about the population health overall. We work with social scientists and geographers who work normally with statistical information in indexes like the Scottish Index for Multiple Deprivation. They model health outcomes using numbers and kind of statistical information. They kind of do clustering to predict how healthy populations in different areas are. And then there are, of course, also public surveys to ask for information about health. So Professor Linda Bald has just launched a survey recently asking for the population in the Lothian area to submit their data. But generally, these kind of ways of research can't easily capture information such as social and community cohesion. So the project we are working on is trying to analyze news articles and social media over like the last 5 years to see if those kind of topics can emerge from the news articles. So yes, the answer is yes. The preliminary results are showing that there are certain topics, for example, social support and charity that are present in news that help predict health outcomes in different areas, and we're still in the process of kind of finalizing the results, but the answer is yes.
That sounds good. Could we see the answers? No. About 50-50, yeah. That's quite good. That's a challenging area. Thanks so much, everyone. So moving on to Jo. So for her, we asked the questions whether you think public members play a major role in defining the focus of the Advanced Care Research Center.
Thanks. Hi, everybody. I'm a layperson, And to put that into context, I know virtually nothing about artificial intelligence. I was here yesterday and I attended the children's session, which was brilliant, and just about my level of knowledge. I then stayed for Gary Marcus's talk about GPT chat, thinking it was going to be about online chat with my GP. It wasn't, and please don't ask me what it was about. Anyway, back to the Advanced Care Research Centre, where I'm involved in the group that's looking at multiple long-term conditions. I know one shouldn't make assumptions, but looking at the audience, this probably isn't something that most of you have to worry about at the moment. But believe me, the older you get, the more time you spend talking to medical professionals, and you begin to lose count of the number of pills you take every day. I've been involved with the NHS in a non-clinical capacity for about 35 years, and latterly as a layperson in medical research. 10 years ago, it appeared to me that subjects chosen for research were at the whim of the researcher, rather than considering the needs or the priorities of the patient. All this has begun to change, with patients and carers being asked what is important to them, frequently things which had never occurred to clinicians. This is very much starting to influence the direction of research. Quality of life features very highly on patients' lists, and how to remain self-sufficient and in one's own home for as long as possible. Artificial intelligence has an enormous role to play in this, and new gadgets and systems are constantly evolving, many of which are due to the input public members are having. So more of this later, and as far as I'm concerned, the answer to the question is yes.
Okay. Great. So what did you think? And if you can display the results? Oh, that's good. Then we are probably doing a good job with PPI. That's fantastic. Thanks so much, everyone. So lastly, Peter. So for Peter, we asked the question, whether you think that less than 10% of drugs which enter in human clinical trials receive approval. Peter, what's the right answer?
Thanks, Sohan. Yeah, so just by way of background, I started out as an engineer. I'm now comfortable calling myself a generalist, but some of the technology that I worked on at the beginning was how to extract information from medical images, both to drive clinical research and also to help doctors make diagnoses, but also what's now commonly under the umbrella of artificial intelligence. So using data to learn patterns and applying that knowledge to detect new events. So things like patients getting ill or jet engines needing to be repaired. But for me, what's really important is that you have a really collaborative combination between the technology, but also the people and the processes, because technology on its own is just technology. It's not a proper solution. And when you start to think about the way in which drugs are developed, some of you may be aware that there's an increasing interest in how artificial intelligence can be used to help sift through all the possible combinations of molecules and start to shortlist some chemicals, which then can go on to be potentially developed into drugs. But the development pathway for drugs at a very high level is a long one and consists of stages. You have this discovery where you're working very much in the lab with chemistry. You then, if your drugs seem to indicate that they're going to have some kind of therapeutic effect and they're also safe, will then go into first small limited clinical studies, and then subsequently, if they continue to show their efficacy, will then go on into larger studies which start to demonstrate that the drug can have the effect that you want on much larger populations of people. But all of this takes a very long time. It costs a lot of money. It involves recruiting patients into the studies, making sure they stay in the studies. People do naturally drop out of clinical trials, and actually the cost to replace someone in a clinical trial is 3 times as much as the cost to get them selected, find them, and trained and brought on board in the first place. So retention of patients is an important and costly process. And when you think about the intended use of the drug, there's you have more common conditions where once the drug is developed, you can expect to achieve a kind of almost some degree of an economy of scale, because it's available and can be offered to a lot of people, and you can take advantage of that. But I'm sure everyone will be aware that there's examples of very, very expensive drugs that hit the market, and often, but not always, therefore, what are known as rare diseases, which affect a relatively small number of the population. But nonetheless, collectively, there are a lot of people with rare diseases, but there are 11,000 of them altogether. So when you're thinking about it, costs about the same to develop a drug for a rare disease as it does to develop one for the flu, let's say. So when you get to market, you need to think about recovering those costs. And that's where some of these interesting and political conversations around how much does the government subsidize drugs comes into play. With all of that said, there's a lot of steps that happen before you go into human clinical trials, but also a lot of steps you need to go through. So probably that's a good point to look at whether or not what people thought. And the recent number I saw for this was about 7% of drugs that actually get to the point where they start to be tested in humans actually make it onto the market, which also creates an opportunity once drugs are available. What can technology use to help us make sure people who are eligible for those drugs actually are aware of them, their doctors are aware of them, and if appropriate, they're being prescribed them and they're actually getting access to them. So that's another important role of technology, I think.
Great. Thanks so much, Peter. So what did you guys think? 100%. Great. Fantastic. So everyone knows everything already. That's a good start. Yeah. Thanks, Sarah. And okay, great, fantastic. So that was the introduction part, and after that, as we said, we wanted to have open and inclusive discussions on a few points around later life care and AI. So we have 4 topics that we'll put up on the screen and discuss. And if you have any questions, please feel free to submit them. We'll try to go over as many questions as possible. And as Sarah pointed out, she also has a mic, so if you have something to share with us, comment, lived experience, please raise your hand. We'll bring you the mic so you can share your thoughts with us as well. So on that note, let's see if I can change the slide. Great. So to start with, one of the first topics that we wanted to discuss is something that is quite core to our agenda at the Advanced Care Research Center. What we want to do is that we want to promote healthy aging, and we want to enable people to live independently in their later life. And technology and AI can definitely help quite a bit there, and they can really revolutionize the way we certainly do things. And even if you think about simple devices which can measure your blood sugar and keep track of what you are doing, so that can be shared with your healthcare provider. That is a simple device, quite readily available and less intrusive. But if we think about other devices, for example, video monitoring and things, or smartwatch, they are definitely more expensive, and also they are a bit more intrusive because they can collect personal data. So the question is that if we have the opportunity, and we know that we can change a lot of things, the way we perform care in later life care, then how do we do that? And the device and the technology that we are building, are they really inclusive enough and ethical enough or not to be deployed at home to monitor, diagnose, and treat? On that note, I wanted to bring in Peter here first. And Peter, what are your thoughts about this?
Yeah, so I mean, I know Claire, as a real doctor, is going to talk about some practical examples of this. But from my perspective, I think I wanted to start by sharing a kind of a motto that someone taught me a few years ago when you're thinking about how to use technology to solve these problems. And it's fall in love with the problem, not the solution. Because I think if you get too fixated on the role of tech early on, it can mean that you end up developing in a very narrow way a solution that, even if it does, let's say, get into the hands of patients, very rarely tends to stay there or scale and achieve the benefits that we all hope technology will do in providing capacity to healthcare systems of today. So when we look at, consider words like inclusive and ethical, the first thing is, I on my own, let's say as an engineer, have no way of accurately determining if something's going to be ethical or inclusive for anyone else here. The only way you're going to work that out is by talking to them. And while, there's been phrases like co-design and collaborative development that have kind of bounced around for a few years, I think that more than ever they're particularly relevant when you talk about inherently very high-tech approaches like data and artificial intelligence. And there are a number of very well-established design approaches that have been around for a while, things like design thinking, where you're encouraged to spend a lot of time with people who stand to benefit, and potentially those who could stand in the way of your technology being used, and really dig below the surface and try and understand what do they expect to get out of it, what are the potential benefits, what constraints do they operate in. Claire, I know you might touch on some of the kind of practical constraints when you might try and build a tech solution for healthcare. and really make sure you understand what the problem is before you dive into trying to solve it, which is hard for engineers because we like solving problems, right? But actually it's much more satisfying to solve a problem that you know is going to have lasting benefit, I think. And so that kind of that co-design, that iterative approach where you really focus on empathizing with the people who are going to be the ones using your technology at the beginning of the design process is absolutely critical. I think on a practical level, when we start to talk about the application of this technology within homes for things like managing multimorbidities, you know, we've got to consider how the environment, the built environment, is part of the solution, even if we're thinking about building a particular device. And you know, coming back to my role with the Institution of Engineering and Technology, and the IET is a very broad professional engineering organisation, so we've got about 150,000 members across the globe. A lot of them are in the UK, but you know, unlike the Institute of Civil Engineers or the Institute of Mechanical Engineers, we cover the whole gamut from data through to the built environment and energy. And I think that's a really important and interesting perspective, because I believe the future of hopefully preventative healthcare is not going to be about getting better at detecting disease and curing it. It's going to be about creating environments where we stay healthier for longer. Not that we just react faster to people being unhealthy. So that's the kind of the long-term vision. So I think point number 2 is you need to consider the environment in which you're going to be deploying a system, particularly when it's the home, because that's going to have benefits and constraints. And then the third point I wanted to make is that, you know, the enabler for this is data, and for that to be a reality, there are topics that come up time and time again, like interoperability. You know, how do different systems talk to each other? And again, it can be tempting to think the solution to interoperability is just a software problem, like it's just this, you know, my Mac can't talk to my PC, and if I could fix that communication problem, that's interoperability solved. But again, we're talking about a system that is a solution that is a combination of technology, people, and processes. So interoperability is not just buying all of your equipment from one manufacturer. So it's a harder but a more interesting problem to solve. But at the same time, if we're going to expect people to, we talk a lot about trust, and that's correct, but trust on its own isn't, I can't do trust. What does that actually mean in the context of healthcare? And quite honestly, I think people need to see short-term benefits from sharing their data. You know, I'm embarrassing, quite Luddite. You know, if I'm on the internet and I go to a website and it says, well, you know, gives me all the cookie form comes up and says, you know, are you willing to share your data? I'm the person who will sit around and spend far too much time going, no. And then if I don't get the thing I want, after he goes, well, I'm really sorry, I can't show you that web page, I'll probably go back and go, actually, it's okay. I'll put that back. And I think it's that transactional bit, which is really important. It's human nature. You can theorize all you want about the longer-term benefits of having everyone's data and enabling preventative healthcare and putting care into the hands of individuals. But quite honestly, if people don't see the short-term gains, they're not going to do it often enough for it to have an effect. And that goes back to what I was saying about clinical trials. It's about having sticky solutions that actually are effective because they are with people and become part of their habits. So without further ado, I know, Claire, you had some really great tangible examples of how that could happen, I think.
Thanks very much, Peter. It's really fascinating to hear what you're saying about this. I think I actually missed introducing myself at the beginning. So my name is Claire McRae. I'm a GP. I have an MRC clinical research training fellowship to do a PhD. Got that in 2021. And the PhD is at the University of Edinburgh at the ACRC. Throughout this process, learning data science methods to better understand how health geography interacts with multiple long-term health conditions. And we're also exploring how we measure long-term health conditions using data, because you've got lots of data, but how does that actually make sense in a clinical perspective? So really enjoying working on that. I also work as a GP in NHS Lothian as well. So I've had a bit of a think about how we make AI tools inclusive and ethical, because that's absolutely the linchpin of why we're doing it. Following on from what Peter has been talking about, thinking particularly about a technology we can all imagine using, like smartphones, so using them in people's homes, because that's the technology people tend to have access to. And I guess the way in which that's problematic is if people have cognitive impairment that's moderate or more severe, if people have difficulty with visual impairment or reduced dexterity, manual dexterity, or if people don't have the financial resources for smartphones, then they're going to be excluded from this. And I guess the worry as a clinician is that actually makes the health inequalities that we see, it makes them worse. and that's a big concern that I have about them, but I think that's an opportunity as well to improve what we do. So the upshot of that would be that often the people that have the greatest need are going to be people who are older, who have more health conditions, and the people who have the worst health. And it's challenging for them to use sometimes these technologies. As Sohan said, we've got a nice example. There's lots of advances in technology in the management of type 1 diabetes over the last few years. And that's helped by it being a very specific problem. It has a specific role to do, to perform glucose monitoring and sometimes actually administering insulin to the body, life-changing, which is fantastic. But it tends to be quite a young and motivated population, so it's a tangible problem, specific solution, and it's a population that tends to be able to use these technologies. The problem arises where the solutions are less specific, less tangible, for people that are going to be more challenged to access these technologies. So what's absolutely essential is that the design of these technologies work for the people that need them the most, for the people who are most vulnerable, but they also work for younger people and people that are more able to use these technologies. And that needs to be in terms of both the hardware, so the actual physical technology that we have access to, that so there's no barrier, and also the software and the user interface and how we do that. So if there's difficulty with visual impairment, that you have auditory input. If people have difficulty with manual dexterity, can you use foot pedals? Are there other options? So we need to be engaging with stakeholders, just like Peter said, to make sure that these solutions meet the needs of people who need them the most.
Great. Thanks, Peter. Thanks, Clara. And we have quite a few questions here. And I think one of the first question, I can probably hand it over to Peter. The question is, as you all know, it is extremely difficult to get GP appointment in the UK. How feasible it is to replace these appointments with a preliminary checkup by an AI-trained healthcare data?
This is an area people have been working on for a while now, I guess. One of the interesting things, if I can sound slightly optimistic, that COVID brought on was it kind of forced people to try out technologies like telemedicine, which were always seen as a nice to have. But I think also at the same time, you've got to consider that whatever people did during lockdown to enable telemedicine and automatic care was an experiment. That's not the final product. So I think we learned a lot from it, but we learned what we still needed to do. I think particularly when you're looking at trying to release the capacity issue at the GP level, there's a lot of things that need to come together which aren't just about the technology. So, for example, there are actually the way the budgets are handed out for some healthcare systems penalises you. It requires you to have a certain number of in-person appointments. So it can seem quite counterintuitive, but actually until the procurement changes, we're never going to be able to deploy technology more widely. But I think more from a kind of a clinical standpoint, we need to be quite, well, we won't do it now, but we need to be quite specific about what problems we're trying to solve, because clearly GPs by definition see a very wide range of conditions, and the more claims you make about what your technology you do, the more the evidence burden on the people developing it rises. So I think this is where that may seem a bit of an insurmountable challenge. How do I develop a bit of technology that can diagnose every disease that a GP might be able to? But I think then you need to take a step back and again look at the context, look at the whole user journey, and then use that to understand what you can pull out of that journey and go, well, actually maybe it's not replacing the GP with a technology that can automatically diagnose everything and then refer people to the appropriate hospital setting. But maybe what we're doing here is we're using it to accurately prioritise which patients need to get seen first and take sort of smaller bite-sized chunks of each problem. So I think it is possible, but again, it's going to require a concerted collaborative effort between the system, the people who pay for the technology, and also making sure that there's genuine trust amongst both patients and clinicians that they're right to be handing over some of this to a technology solution.
Could I add something?
Sure, please.
Very quickly. So I completely agree with what you're saying. I think working kind of clinically, I'm pretty committed to the value of face-to-face contact with people, especially people who are more vulnerable and have lots of ongoing health needs, particularly visiting people in their homes. And I think that can't be replaced. But what AI can do is free us up so that we have more time to do that. Because I think if I go into work and have a 10-hour day, about 5 hours of that is seeing patients, and about 5 hours of that is interacting with my computer. And I think there are so many ways that that could be made more efficient, and that we can really have the time to have that interpersonal connection, which I think is helpful.
Thanks, Peter. I think in the interest of time, let's move to the next question we had. So we talked about a bit of tools that can be deployed at home, but there are also quite a bit of advances recently in AI tools being developed for clinical prediction. And you probably heard about the recent progress that has been made in detecting breast cancer from scans. And AI is quite remarkable in early detection of those diseases. And there has been a lot of work around AI as well in looking at clinical data and trying to predict adverse outcomes from clinical data. For example, whether you will have a kidney failure in the future or not. Now, this kind of prediction tools are great and effective because they can look at a lot of data and to build that algorithm, which humans themselves cannot do. But if we have these tools, it also brings extra responsibility, for example, of accountability if the tool is solely being used to make a decision, and also some explainability if we have to explain the decision made by that tool to the end user, clinician, or patient. So, but given that it will probably be quite available in the future, but we have to still understand these things a bit better of how they can contribute to your healthcare. I wanted to get the panelist opinion there as well. Claire, let me bring you in first. Since as a GP, you probably have seen or heard about these tools, or probably hopefully now or being used in the future. What are your thoughts on that?
Thanks very much, Sohan. So just as a bit of background, in primary care at the moment we don't routinely use a lot of artificial intelligence tools. We use more conventional tools that are decision tree based. And the problem with those there's two main problems. So one is that they tend to over-predict risk of particular outcomes because you don't account for death or other adverse outcomes due to other causes. So, for example, if you're doing a study looking into risk of heart attack, if someone dies of cancer, then you attribute that to the risk of heart attack. And the second one is that the tools that we use just look at one problem, and that's really not what life is like. So clinically speaking, it's quite rare to have somebody who attends who has just one problem. And also we can see that from the research that we've been doing. Lots of people have multiple problems. So as an example, atrial fibrillation, where your heart beats irregularly, puts you at an increased risk of stroke. GPs need to use two tools. So one tells us if you should if you should start a blood thinning medication. And then we need to use a second to tell us whether that blood thinning medication is safe. But both of those tools are trained on different data sets, different populations. And also, it's difficult from a clinician's point of view because you need to spend time entering into two different clinical systems, so it's not efficient. So thinking of what we have available already, it's unclear if AI actually outperforms these conventional models. So another model that we use often is QRisk in England and Assign in Scotland, and that tells us if somebody is at risk of heart attack and stroke and needs to start on a statin. So this is quite a common cause for presentation to primary care. And a recent study showed when they compared the model that exists that used conventional decision tree analysis versus machine learning, and there wasn't any evidence that machine learning was better able to predict. So artificial intelligence, I think the gap in the market really, I think from a GP's perspective, what we would really like, I think what would help are models that can look at multiple outcomes, because people are more complicated. And I don't have any solutions for this. It's a lot of work, but that's the kind of the direction that would help. And accounting for risks of different problems, so that you're not predicting the risk for these one causes. And it really needs to be persuasive. So it needs to be persuasive to patients, it needs to be persuasive to clinicians and to guideline writers, because if it isn't, it won't be taken up. And we need to pay attention to what what is persuasive. So, and that's going to involve a lot of listening and stakeholder engagement. And I think models that are more transparent are easier for us to understand. But you know, I think it's a journey that we need to go down. And for AI to be useful, it needs to perform better than the conventional tools that we have. It needs to be built on data sets that are large and representative of whole populations, and it needs to be implementable at scale, as well as being something that's relatively time effective for us because we're under a lot of time pressure. So,
Thanks, Claire. That's good perspective from the clinician. Joe, can I bring you in now, because you are among all of us as well, are one of the end user of this kind of prediction tools. What will be your thoughts on the question?
Yeah, well, I think Claire's hit the nail on the head when she says that we need some sort of algorithm that will look at multiple conditions. I mean, speaking about it personally, I have a number of conditions, and each condition is treated. I'm not treated, the condition is treated. And I think that's very common. I mean, even in the most simple terms, and I'm not talking AI here, but I'm diabetic. So I'm told, you know, you don't eat much fruit because that has lots of sugar. Yet all the messages you read out there are eat your 5 pieces of fruit a day, or sometimes even eat your 10 pieces of fruit a day. So which one's right for me? You know, is it what's right for the diabetes, or is it what's right for the whole me? And there's nothing that seems to help me make that decision. You know, so when the GP or whoever goes through the algorithm about my susceptibility to a heart attack or a stroke, you know, is the answer they get from it, can I trust the answer that comes back from that algorithm? You know, how honest is it? And, you know, talking about honesty, I'm told, I mean, not me, of course, but most people, when they're asked, how much do you drink? You know, they reckon that the GP halves what you say. I don't know whether that's right or not, but, you know, so it's in the patient's gift as well, this honesty thing. We need to be honest as well as, because otherwise, certainly, we can't trust the answers. I don't know whether you want to comment on that, Claire.
I think I've become slightly obsessive about data over the last year and a half, and I think there are major constraints in terms of the data inputs that we have, and I think that we need to work with the providers of the interfaces so that the information gathered in the consultation is recorded and in a robust way that we can then use to train and provide models. Yeah, it's difficult at the interface to know to what extent the patient is disclosing the reality of the situation, but I think that's where it really comes back to stakeholder engagement. If people genuinely feel that these models are trustworthy and they're in their best interest, then I think people are more likely to give the answer that's correct. So.
I think that's a fantastic question, very related, is that from the perspective of a healthcare professional, how much do you trust the metrics produced by a smartwatch or other mass-marketed body sensors? Do you trust it enough to make a medical opinion from that data?
It's really, really interesting, the question, and I haven't looked at the research on this, so I don't have a kind of sophisticated answer to it, but I certainly think that it's increased the number of consultations that we have, and I think in some cases it's helpful, in some cases it's less helpful. I think it would need to be validated to know exactly to what extent we can trust this information. And I think in some circumstances it's particularly useful. So I think if you have a cardiac arrhythmia, potentially it's more useful than if you don't and you're just screening and you might be catching a lot of noise. But what I know for sure is that it's something that we spend a lot of time clinically speaking to patients about. And I think that's where Peter's expertise comes in so useful. It's about this interface between the developers of technology and clinicians and patients, and we have to be on the same page. And I think if one side goes ahead without the other, then we can end up kind of picking up the pieces from one of the sides of that triangle.
Thanks so much, Claire. That's fantastic. I think in the interest of time, again, I'll try to move on a bit to the next question. We wanted to quickly discuss that So we have been hearing a lot about trust in the topics we have been discussing, and one of the ways, probably if not the only way to build trust, is to raise awareness of AI in the community and with our public members and practitioners. And there has been quite a big push in that direction. So whenever you get research funding nowadays, you have to have a patient-public involvement and engagement panel in place with the funding to make the research more inclusive and make sure that it is getting used by the end user and they know what is being done. But is that enough, or do we want to go a step further? And if we want to go a step further, how would you want to engage the users more and take into consideration their lived experience in the research we are performing? And as Jo is our patient and public engagement member, I'll ask her first, what are your opinion on this?
Well, whilst appreciating there is a difference between want and need, I do think that a lot of it is about educating clinicians to listen to what patients want, rather than the clinician thinking that they know what the patient wants. You know, as far as spreading the word, as it were, we're going to talk about social media and so on in a minute, I think. But there are a lot of self-help and support groups out there for just about any condition you could mention. How often do the clinicians use those? Some more than others, I would suspect. I mean, speaking about the ACRC, they're certainly very good at engaging with the public when it comes to research, but how that research gets disseminated throughout the system, I'm really unsure, and I suppose I'm asking for the answer to that question as well.
Thank you. I think maybe that's a good time to bring BA in as well, because she had been quite active with the PPI panel on different research with ACRC and other health projects as well. So maybe what will be your thoughts on that and how we can do it better?
Yeah, so I mean, just to say that so public-patient involvement engagement was not a term I knew about 10 years ago, and I wasn't involved in any engagement with patients at that time. It's now in every research proposal that we write, so there's been a huge change, which is great. I think the first time I've spoken to patients and public members of panels was probably about 5 years ago at conferences, but now, you know, it's very much the focus of research proposals. In ACRC, we've already done a number of public patient engagement events. So at the beginning of the project, we spoke to panels of patient and public members to explain to them what our research is about. So I myself and others work on natural language processing, so it's extracting information from clinical records to help further analysis. And to sort of explain what that means, what the terminology means, how it works, and so on. What we do specifically is extract geriatric syndrome related information, so it's observations about geriatric syndrome and other types of relationships with other information that appears in running text that is written about patients. And what came up very early in the very first engagement event is that the term geriatrics really jarred with some of the members in our panel. It's a standard terminology used in the NHS, so geriatrics care is standardly used. But for us, it was really eye-opening how, you know, the terminology can make people feel, and so we need to be aware of that. Obviously, language changes over time and its use. And for example, in the 50s and 60s, there were terms used in the NHS for specifically mental health issues that you would not be able to use nowadays, that would be completely taboo and considered derogatory and upsetting. So who knows, maybe the same will happen with geriatrics care as well in a few years. I'm not sure. But yeah, so that was quite interesting for us. We then also had a second event which talked about, where we talked about access to data and us, you know, actually getting access to data to do our analysis automatically. We have to inform the panels and the public about how this actually works. And we don't just get given data randomly. We actually have to do data safe training. First of all, our research application has to be checked and approved at several levels. Our software that has to be installed in a safe environment, so it's also called a safe haven, some of you might know, has to be approved and then checked again by IT security before we actually end up getting access to data and everything gets put together. And so there's a lot of loops, and of course also the reports have to be anonymized as well first and checked and double checked. So for us to actually get a hold of real clinical text is a huge process. It takes a long time, and it's not something that happens kind of overnight. So, and of course the awareness about this has to be made much wider, because I don't think a lot of people would know about that. And then of course last week we ran a third event, which is a satellite event of the summit. It was organized by Dr. Arlene Casey, who's in the audience. Arlene, if you want to wave your hand. So if you're interested in talking to her about later, then please find her. So that was called Your Care, Your Future, a Creative Exploration. And there, the main outcomes were, so patient-centered care needs to be kind of in the center of everything. AI should help and support patients, but in the end, it needs to be about the patient themselves. One other point that came out is AI should take the burden of carers and patients, and a good quote that came out of it was, let carers be carers and patients be patients and not form fillers. So for us to try and make use of AI technology as best as possible to do kind of the things that then would give you more time, and the same is true for you, what you mentioned, Claire. So it's along the same lines. And then another plea, actually, which was interesting, was that the members asked for the AI to be developed not for this current generation of older adults, but for ones in 20 or 30 years' time, who might already be a little bit more familiar with using technology, certain types of technology, and social media, for example. But of course, there are limitations, as Claire mentioned, that could occur, like to do with dexterity and illnesses that would prevent you from using a smartphone, if you have a certain condition, for example. And then the last and really interesting point, which might answer Joe's question, is that there was a plea to have GP practices become community hubs. So rather than you just go to your doctor and get treated for whatever illness you have, that the GP practices actually open the space to invite patients and the public in maybe once a month or every so often to talk about different topics, and that could include informing people about what research goes on in different areas, for example. So I thought that was quite interesting. Of course, practically, how to do that without stretching the NHS even further is another question, but it's an interesting point. So.
Thanks, Liz. Thanks so much. Yeah. I think there is one question which you probably touched a bit, so I'm just going to say that question. It's quite interesting. It says that I am a strong believer in sovereign data ownership. In healthcare, this would mean the patient owns their medical record as opposed to the healthcare provider. Do you feel this would have benefits to the industry, or at academia as well, to it at large? And what issues do you see this creating with the current model?
So if the patients own their own data rather than it's kind of owned by the healthcare system, yeah. I don't think that's a big problem. I think that would be okay to do it that way. It would obviously need to be put in practice, like in terms of systems and stuff, and technology. What happens in my field is, like, we have a real lack of clinical text data to work with, so we have to go through this long process to get access to it, and our data has to be anonymized before we can even lay eyes on it. if patients own their own data and could then contribute it as a donation to research, that would be something that is of interest, and there are already discussions in the UK to create a DEX data bank of data donated in that way. These kind of data set exists for the US, but we don't have them in the UK, unfortunately, yet. So, so I think potentially, owning your data, but then also contributing it, if you were willing to, would be something that I would think would be beneficial.
So a co-ownership model.
Yeah.
Thanks so much, Bea. And I think we had another discussion point, but we also have a lot of questions. So I think probably addressing the questions will be fantastic. One of the questions, I think, Peter, if you can comment on it, that would be great. The question says that, do you think the acronym phrase AI has now become unhelpful when describing healthcare solutions? Has the perception of AI developed in a way that could put off the people who might benefit from it the most? How might this solution be better described to offset the perception of the term AI?
I think all acronyms and buzzwords are dangerous because they don't tell you exactly what you're talking about. I think this is one of the real challenges when you're trying to drive real collaboration between sectors. You have people who are experts in their respective domains coming around a table with all the common, hopefully no one disagrees that we need to keep people healthier for longer. But as experts, it can be quite hard, latently to break down what you're actually talking about without using this kind of proprietary secret language that you use to talk to your peers. So, yeah, I think if we end up reducing it down to just 2 letters, everyone's going to have a very different interpretation of what those 2 letters mean, and so I think it really kind of emphasizes the importance of making sure, if you're going to collaborate with people, people need to have the same basic understanding of what the technology can and can't do. Or, even if you just think about someone from a technology background working with a clinician, if you as a clinician, when you see patients, you have in your head through your training and your experience a number of solutions that may or may not be appropriate. Now, I always believe if you've got a really good idea of what artificial intelligence, machine learning can and can't do at this given point in time, you're in the best position, you're on the bleeding edge, you've got the most information about the problem you're trying to solve, and you're the best person to say, yes, it can, or no, it can't. But I think if the level of understanding is AI, then you're like, well, maybe it can, I'll work that out later. Nothing ever gets done. So I think we need to be a bit more concrete about what we're talking about here.
Thanks, Peter. And there's another question, quite interesting. Maybe I'll pass it on to Joe. The question says, thinking of patient-centered care for people in later life, should we be aiming to create models to inform us when not to do things? For example, when to stop medication?
I think that's a really difficult one because everybody has their own ideas. And I mean, I would say it's up to the individual patient, to be honest. It's a personal decision. You have your optimists and your pessimists, don't you? You have somebody who says, if I'm starting to develop dementia, please put a pillow over my head. Whereas the other side will sort of say, no, keep me alive, whatever, because research is changing things all the time, and perhaps next week there'll be a cure. So I think to generalize with something like ending somebody's life, in effect, it should be a personal decision.
Can I just, I've got one point about that.
Yes.
So I think this is where the multiple outcomes tools would be really helpful, because so essentially what we need to know about is the interactions between drugs and disease. And that in many cases means reducing drugs, and it's not about saying this is end of life, this is palliative, this is about this is actually going to be better for you, and we're going to have less problems in the future because you're on fewer drugs, because the drugs are causing problems. And I think working...
It's the quality of life
It's
thing,
the quality
isn't it?
of life, it's the choice, and actually knowing the ins and outs of whether things are helpful or unhelpful. And I think that's where AI potentially could be really helpful for us.
I think we have like a minute left, so I'll add one last question to Vivek.
1 minute.
Yes, 1 minute. We have to be very quick. So how do we ensure data are representative of our population if we only are getting data from those who are present to healthcare? We are missing a huge part of the actual data needed. Is that true?
Yes, that's definitely a problem. I mean, absolutely. So we try to use methods like random sampling, but if the initial data set is already very skewed, then that won't even help with that. So it's definitely an issue. Yeah.
That's fantastic then. So wrap things up now.
So many questions and so many. Yeah, I'm hopeful that you'll be around over lunch because it's lunchtime now. So thank you, and please join me in thanking our wonderful chair, Sohan, and our wonderful panelists. Thank you so much for that. Thank you.